Thank you. Welcome, and thank you for joining us today for the meeting of the New York City Health and Hospital Equity, Diversity, and Inclusion Committee. Today's meeting is officially called to order. We are going to come back to the agenda and the minutes for the from our meeting on June 7th later on during the meeting. But so we are going to go with the second item in our agenda, which is the diversity and inclusion update from Mathilde Roman. Mathilde?
Thank you. Good morning, everyone.
Good morning. Good morning.
I want to begin giving you an update on progress made within the Office of Diversity and Inclusion. As you know, in response to the Afghan crisis, we have really kind of made a concerted effort to prepare in the event that the city would receive Afghan nationals in the city. And so the Office of Diversity and Inclusion took the following proactive measures. We gathered information about the federal government's response and of those actions that would directly or indirectly impact both the city and health and hospitals. We work with our language service providers to determine their current capabilities and steps that they were taking affirmatively to ensure interpretation and translation services. We met with the mayor's office and New York City Office of Emergency Management to really kind of understand what they were currently doing. For us, our point of entry is not going to be New York City. It is Dallas and it's Philly. So we are not having a direct impact, but we can anticipate that given the sizable population of Afghans in Brooklyn and Queens, that we can see some individuals kind of transitioning or migrating here into the city. And so they are prepared for that flow to happen. And so that's the work that they're doing. We've also reached out to a number of other resettlement agencies in New York, CAMBA, Catholic Charities, and IRC to kind of get a sense of what they're doing. And currently what they're doing is they're moving individuals that they're receiving, and they're very small numbers, to Long Island. And then last but not least, we reached out to the Bellevue survivors on torture. So Dr. Keller can, one, be aware, but also inform us of any changes. And so he's going to keep a pulse of what's happening and also tell us if there are any changes or shifts that we need to be mindful of so that we can respond if individuals come through health and hospitals. And I'll pause here for any questions or comments.
Thank you, Mathilde. Let me go through the members to see if there is any question. Jose, you are here. Jose, any question?
Yeah. No questions, thank you.
Thank you. Dr. Allen, on behalf of Dr. Katz, do you have any question?
No questions.
Thank you, Dr. Allen. Sally,
No
any
question.
question? Is Frida on the line? I don't see her. No? Okay. And Michelle, I know Michelle sent me an email that she was going to send somebody from Department of Health and Mental Hygiene.
Yeah, hi, it's me, it's Shadi. I don't have any comments, thank you.
Thank you, Shadi. Okay, maybe we should know that Shadi Shamani is going to be representing Dr. Michelle Morse. So for the stenographer. I just have a question from my side. You mentioned that the small numbers that we are getting, some of the groups that work with refugees are sending them to Long Island. Is there any particular reason why that is the case?
We don't have a particular reason of the rationale for why. That was what we received from the Mayor's Office of Immigrant Affairs, that currently IRC had received approximately 14 individuals and that they were resettled in Long Island. But other than that, we don't have any further information to inform the rationale why.
Oh, thank you. I also have another question. I know that we have been working very diligently, and I bet we are going to be talking today about the language. Do we have translation into Afghan? Is that part of the preparation, or is that something that we already had?
We already had, but we wanted to make sure that we increase the pool of interpreters and translators in both Dari and Pashto. And so those are the two key languages for Afghan nationals. And we are adequately prepared to both communicate both verbally and in writing to Afghan nationals if they present themselves at health and hospitals.
Thank you. Thank you. I don't have any other questions. Thank you so much. I'm glad you have been working so diligently and being prepared. That shows your commitment and dedication of you and your team. Thank you.
Thank you. And so moving along, over the last several months, I've been doing site visits just to get a sense of, one, sharing the progress made in diversity inclusion to all our facility executive leaders, key HR teams, and other key stakeholders across the system. And these have been the key findings thus far that we were able to kind of synthesize. And so one is aligning the Plain Tree certification. They raised that there's a lot of synergy in the diversity and inclusion work that we're currently doing, and that they were very interested in making sure that the work that we were doing was aligned with the Plain Tree certification. And so, we're currently working with a number of sites to ensure that we are supporting them in their process for certification. We also heard that they wanted expansion of diversity and inclusion training opportunities, more than what we already have. We have a variety of different training opportunities available, but some of the needs needed to be customized, and so we're looking to explore that, and I'll talk to you a bit in future slides about that effort. Also looking at language services and how do we increase capabilities by leveraging technology, both vis-a-vis the equipment and the types of tools that we can use in order for us to ensure greater access to language services across the system. And also thinking about how we can support HR in providing additional tools to support both diverse hiring and for hire for difficult to recruit positions, so we can ensure diverse talent across the system. And lastly, looking at expanding and enhancing the talent development initiatives that we currently host, so that we can really bolster retention. And so it kind of segues nicely into the diversity and inclusion training updates. We released the first system level D&I training request for proposals in late August. We have a good number of diverse training vendors who are interested and hopefully will be submitting proposals. And so that's work is underway, and that's in response to what we've been hearing at the facility about wanting to increase more training opportunities. We have launched a voluntary in-house interpreter skills training for bilingual staff. It's currently available in Spanish, but the hope is that in future state, it'll be expanded to additional languages. And so really our intent is to really build in-house capacity for individuals to communicate with patients and serve as a bridge for limited English proficient patients and visitors. We also have collaborated with PAGNI to enroll all their providers into the LGBTQ Health Equity Certificate Program. And now we are currently underway in enrolling individuals that are in Mount Sinai upon the request from both Queens and Elmhurst. And so we're working to enroll them and get them in their certificate program to really enhance providers as affirming providers across our organization. And in the month of July and August, we completed over 6,800 trainings across the system on a variety of different topics, including unconscious bias, diversity and inclusion, best practices, and LGBTQ related topics, and interreligious awareness. And last but not least, we have updated the consent forms. Dr. Allen in Medical and Professional Affairs has legal and regulatory and compliance. We have updated all the consent forms and key patient-facing documents and have them now available not only in English, but in our top 13 languages. And now these key documents are available both in our essential documents library that can be found in all of our desktop computers across facilities, It can be found in the Diversity SharePoint site and on the Forms tab on the H&H Insider. Happy to, and that completes my update, and happy to field any questions that you may have at this time.
Thank you. Let me go over the members. Jose, any questions or comments?
No questions, just great work. Really appreciate it.
Thank you. Dr. Allen?
No questions, thank you.
Thank you. Sally?
Two quick questions. Do we currently have a vendor that's providing DNI training?
Can you repeat the question, Sally?
Do we currently have a vendor that's providing DNI training? I see that we're issuing a request for proposals. Do we currently have a vendor on board, or is this new?
We have multiple vendors that provide these services currently.
Okay.
I think it's really an opportunity for us to explore different types of learning solutions and platforms. What we've learned is that, there are areas where there is niche kind of needs, whether it's correctional health services or it's in looking at hospital police. So there are opportunities to really expand the current content to ensure that we are meeting the unique needs of both departments and facilities.
Okay. And my second question, which doesn't have to go into detail now, but I know, based on feedback at a number of different meetings, that the reading level of our patients is very low at the literacy level. And most of our consent forms in particular, I'm thinking, are they in kind of very simple English?
That's a great question. And so as part of our process for translation, our team, the diversity and inclusion team, does plain language and health literate reviews even before it goes to translation. And we actually work with our key stakeholders to work on ensuring easy to read documents for our patients. And so that is part of our process to ensure, because a strong, easy to read document translates well. The other thing that I want to flag is the fact that we are now moving forward in creating the documents for individuals who are blind or low vision. And so we're creating large print fonts in the top languages, Braille, as well as look at audio files for these key consent forms.
That's terrific. Thank you very much.
This is Michelle. I have a question for Nicola in terms of outside vendors who are supporting us. Nicola, are you still on? I don't.
Yes.
Yes.
Yes, I'm here.
Are we still entertaining working with the Perceptions Institute?
Yeah, we've had a couple of meetings with them, and since the office has put out an RFP, they're going to be responding to the RFP, and so
Right.
they'll be in the pool of vendors that are responding to the RFP.
Great, thanks, Nicola.
Thank you. I just have a question, Mathilde. I just came from the committee, IT committee, and of course, the MyChart is one of the very important tools that are used to communicate now with our patients. Do we have, I know that we had a discussion earlier about the languages of MyChart. Do they have the 13 top languages that we have, or no? I remember last time we talked that there were some that they didn't have, but I'm not so sure.
And we're working to make that happen. So, there is a commitment to really expand the availability of MyChart in additional languages. It's currently in Spanish and some other languages, and French, I believe, but not in all. And so IT is actually working to ensure that we expand languages for MyChart. I just don't have a timeline.
Oh, thank you. Because in the report that in the previous committee meeting, we are already now on 70, going to 75, and some of our sites are already in 80, 85. So you can imagine that we may have to look that more closely and see when that will be, if that's going to be the future of interaction with our patients. Thank you. Any other questions?
Yeah, hi, it's Shadi. I have a
Hi,
couple
Chadi.
questions. Yeah, I just wanted to add, your question about my chart, because I know it's come up in the QAPI meetings too. When you, when it's reported the percent sort of uptake, is that just people initially signing on, or is there a way to measure like actual use, active use or something? I'm just curious because you could theoretically have people sign on, but then they really can't use it because of the language issues. So I didn't know how that gets reported. So that's one. And there's a second question, which was about the consent forms. Are the ones that have been translated? Are those in the just like the standard consent for receiving care, or is it specific just, for example, surgery or procedures and things like that?
We have the consent series, and we have additional consent, additional key documents. What we can do is we can distribute the forms that we have available. We have a directory list.
That's great. Yeah.
So we're happy to share that so that you can see what we have available currently.
And with respect, Dr. Shamani, with respect to the first question, I think that's a very good one. We did have a discussion, very brief, in the previous committee meeting, in which their focus was in terms of the interaction and the further use of pie chart. But I do not have the answer if those that data in terms of the adoption of my chart only include the first sign up or includes more use. And I think we can ask, and maybe Yanni, can we try to get an answer to Dr. Chamani about this, asking Kim about it? I know that since Colisha is not here, is that okay? Or Jose, do you have an answer for that? I don't have an answer.
I want to know the answer too.
Okay.
We can do a follow-up,
Yeah.
Dr.
Okay, is that okay, Dr. Chabani?
Yeah, no, it's perfect. And to be honest, I don't even know what the correct measure is. I'm sure somebody who's been working in portals knows better. You know, maybe it's one action, you know, every 6 months or something like that. I don't know, but it just might be good to have both of them. That'd be great.
And we will try to get that answer for you, because I don't think none of us here in this call have that answer, but I think that's a very good one. And thank you so much for bringing it up. Any other questions? I know Frida is not, I don't see Frida here, so okay. If we don't have any further question about Mathilde's report, maybe we can go to Dr. Sineas and Dr. Davis for the report.
Sure, I can kick it off. Next slide, please. So we're going to be reporting out on the different work groups of the Equity and Access Council. Just as a reminder, we have 4 work groups: workforce diversity, workplace inclusion, equity of care, and data and monitoring. So on the workforce diversity work group, I'm co-chairing the work group along with Dr. Elizabeth Natal, and she is the Associate Medical Director at Sydenham. What we've tried to do with each of the work groups is to have co-leadership, both from central office as well as from our facilities, and to have work group members involved from across our system. So for the workforce diversity group, we have 19 members who represent 7 facilities. And we've had several meetings, and our project focus at this time is improving physician diversity. And some of the work that's ongoing there is thinking about how we can do pathway programs for residents as well as medical students to encourage them to come and do electives at one of our facilities so that they can be introduced to health and hospitals. So we're currently having conversations with Morehouse in terms of creating some elective opportunities at our facilities, as well as with the university, as well as the University of Puerto Rico School of Medicine. We're also in the process of creating a survey that will be distributed to resident physicians because we see where there's some potential opportunities to retain physicians, to retain resident physicians from diverse backgrounds. So we're doing a survey to try to understand a bit more about what might encourage residents to stay within health and hospitals once they're completing residency. So we're working on that, and that's the update from the Workforce Diversity Work Group at this point. Any questions there?
Thank you, Dr. Davis. Let me ask the members. Jose?
Just a quick question on the selection of Morehouse and UPR. Like, do we have a lot of physicians from those schools or a few? I was trying to understand the pipeline component of this, or how did that happen?
Yeah, well, those were some contacts essentially that we had. One of the leaders of this work, Dr. Bell, was a graduate of Morehouse, and so he was able to make those connections. And then we had another connection with an attending physician and the University of Puerto Rico School of Medicine. So those were some internal connections that we had, and we're hoping that once we've kind of established some elective programs, that we'll be able to outreach to other schools as well.
That's great. Thank you.
Thank you. Dr. Allen?
I just want to add to Nicola's report that we've been working with the CMOs, and we currently have 3 facilities who have volunteered to participate in this. Jacoby, the head of their plastics and burn unit, would like to work with underrepresented minorities and has volunteered to take residents for an elective there at Jacoby. Harlem Hospital, their chief of GI services, has also volunteered to take residents on rotation, and NCB, chief of internal medicine, the same thing. So there's been active interest and we're moving forward. Actually very excited, the interest, the progress that we're making here.
Thank you, Dr. Allen. Yeah, sounds very, very exciting. Sally?
No questions.
Dr. Shamani?
Oh, I'm good, thank you.
Thank you. I just want to follow up on Dr. Allen's comment and Jose in terms of the kind of institutions that we're going to be looking at. I think I like your idea to start with a pilot, perhaps with our and UPR, and then see, how it's working, and particularly if you already have the connection, the contact. But maybe for the next phase, we may want to look at all the different minority serving institutions and see which one have very robust pre-med programs or medical schools that we can work with. Because I feel that, from my own experience, and Jose can speak from his experience, New York has a certain allure, and particularly if we want to think about Bellevue as one as the oldest, also has certain allure, and I think we can see how we can package our institution as a place where students that already have that sentiment and passion for serving, particularly in urban setting that have been disadvantaged, we can tap into that. And maybe another second level of conversation is to certain foundations that really have been fostering the support of bringing doctors to underserved communities, to see if we can create a pairing in which the financial components can be covered with private philanthropy or institutional philanthropy that sees the value, and particularly with Dr. Allen's comment that how Harlem has stepped up and volunteered. We think we have so much to offer that is how we package it and how we bring it together to really kind of touch those students or future doctors or doctors that have that passion for serving communities that have been underserved before. So I think starting up where you are, I think is good, but looking at holistically, I think it will be a lot of work, but I think that may be something quite helpful.
So I think what we should do, so we're looking at philanthropy and we're following your suggestion, the whole package and the outreach. So perhaps we can give you a more formal presentation about the work we're doing in this area.
I would love that. I would
Okay,
love
great.
that.
Yeah.
And anything that I can help, and Jose, I will be more than happy. I
We'll
don't know if
be
you know,
reaching
but
out.
I don't know if you remember, but I used to be Dean of Engineering, and I believe that my main role was to always have my hand out to get money from donors. So maybe I can provide some of.
It's in my notes, Fenny. We will be reaching out for sure. Thank you for
Thank
that.
you.
Appreciate
Thank
it.
you.
Yeah.
Thank you. Okay, so that's the report for the Equity and Access Council, or do we have more information?
We have 3 more work.
So there are more slides from the other work groups.
Okay.
So, Natalia?
Yeah, we can move through them pretty quickly, but next slide, please. So for workplace inclusion, I serve as the co-chair. I will be selecting, I serve as its chair. I will be selecting a co-chair in the next few months. Currently, we have 6 members and 4 facilities represented. To be honest, we assess the number of work group members, and it's simply not enough to do the work that we need to do. And so we disseminated a survey to join the inclusion work groups, and we are very pleased because we received over 200 employees that are interested in doing this work. And so we will be bringing them together in the next month to assess their interests within each individual work group so that we can begin the work. The work groups that we are looking to establish within the inclusion work groups is the African American Female Physicians Work Group, an African American Work Group, an Anti-Racism Advocates and Allies Work Group, an Asian American Work Group, Diversity and Inclusion Work Group, really focusing around heritage and history, a generational work group, a Hispanic work group, an LGBTQ plus work group, Veterans Disabilities Work Group, and a Women Mentorship Work Group. And I will say when we disseminated this survey, we got some interest to start a Jewish work group as well. And so once we get everyone together, we're going to establish charters and objectives, measurable objectives for them to work on, programs. And when we hire a vendor who is an expert in establishing affinity groups and inclusion work groups, they will also support all of the work groups to ensure we're headed in the right direction. Any questions?
Thank you. Let me ask Jose.
Oh, just great. I really like this idea. I mean, because it has a lot of, you always want to have a place when you have someone things in common with someone else and sort of like cultivate those networks. So that's great. Thank you, Natalia.
Dr. Allen?
No questions.
Sally?
No questions.
Dr. Chamani?
Yeah, hi. Are the affinity work groups going to be separate from these work groups or just pulled out for like specific subgroups? Or is that something you'll let the vendor decide or sort of work with you on?
Good question. So instead of calling them affinity groups, we decided to call them inclusion groups.
Got it.
It should
Okay.
actually not say work groups. It should, because that's confusing because these are the 4 work groups, but it's inclusion groups.
Got it.
Shadi, and these are the inclusion groups topics of interest.
Okay.
The determining factor will not be the vendor, but it will be the employees who are interested in driving these groups for us. And that's how we will prioritize the sort of go live for each of them. So we've already started the African American Female Physicians Group that started by Dr. Davis. And then we're going to launch all of them. We have a myriad of CEOs or frontline staff that are interested in really driving the work, but we will be the drivers, not the vendor. I hope that answers your question.
Yeah, so you're saying for this slide, most of it is really, so you have a work group of 6 members, 4 facilities, but then the inclusion section is really inclusion groups, correct?
No, so initially we sent out a survey and 6 people were interested in establishing inclusion groups throughout the system. We realized that 6 individuals is simply not enough.
Got it.
Therefore,
Okay.
we sent out a survey, and now we have over 200 people interested. And now we will meet with them to understand which bullet they're interested in driving.
Okay. So then work group will change to group in future. I just want to make sure I'm using the right
Correct.
lingo. That's why I
Correct.
asked the question, because when you said affinity groups, I was like, I thought we didn't use that.
No, no,
Okay,
no, we're not
got
using
it.
the term affinity. Most people know them as employee resource groups or affinity
Yep,
groups, but this
got it.
slide will say inclusion groups. So 6
Okay.
has gone up to potentially 200. Once we meet with them, we will know that they are really interested.
Got it. Great.
Thank you. My question to follow up on Dr. Shamani's question is that, are there going to be a budget with these groups in order to allow them to do certain types of events? Because I remember when I was at DDC, we had quite a lot of different events to create kind of community. And we didn't really provide them a budget. We provided support from the HR group, and they charge tickets for all that. But how are you envisioning this?
That's an excellent question. So I think the first thing to do is to align the objectives of the groups to the work that we want and need them to do for the system, which we've already done as a steering committee within the Equity and Access Council Steering Committee. So we know what we want them to do, but again, to your point, they may want to do things such as Hispanic Heritage Month event, and that might cost money. And so that's where we will go back to Yvette and other key stakeholders to determine what is a feasible budget. I've also done work in this space previously to coming here. To your point, there is a financial, need to some of the work that they will do.
Mhm.
Okay, thank you. Again, just thinking about it, because you don't want to set up the false expectations. They may think that, it's supported by the system, encouraged by the system. They may think that there is going to be more than words. There is going to be something else. So, yeah.
And just to add to that, I just got, a notification of someone who wants to come and do virtual dance lessons within the Hispanic Heritage Group because of what we've been through during COVID. So I think there are a lot of people willing to volunteer their time to us right now, but we will definitely assess the financial need as we go forward.
Yeah, and also the one that is very powerful is the mailing list, because somebody want to do a lecture or something and they want to disseminate it to everybody. How that's going to be controlled, managed, in order not to overburden everybody receiving emails from 200 potential 200 groups.
For marketing on our steering committee, and so he's in charge of that. But we will monitor that, so not 40,000 employees get an email.
Thank you. I guess any other questions? No? Okay. I think we have the next group, Equity of Care.
Yes. Next slide, please. So the Equity of Care is another work group, and the co-chairs of that work group are Rebecca Lynn Walton, who's a Senior Assistant Vice President of Behavioral Health, and Shawan Erie, who's an AED of Home Health. So there are 14 work group members representing 9 facilities, and that work group has had some really great meetings trying to think about what projects they wanted to focus on. And I think they've had a little bit of a challenge because there was so much excitement and so much desire to work on different areas. But what they have narrowed their focus is going to be within sickle cell, health IT literacy, and behavioral health. So for sickle cell, the thought is around creating better centers of excellence for sickle cell so that our patients can get equitable care across the system. For health IT literacy, the concern is that as we're doing more telehealth and more things like MyChart, is to make sure that we're not going to create more of a digital divide, and how can we ensure that we are able to educate our patients and have them become literate in this space as well. And for behavioral health, the thoughts on projects around that is destigmatizing the diagnoses within behavioral health. So considerations around training, about documentation, training about how do we communicate around behavioral health conditions. So rather than saying, you know, this is a 50-year-old, you know, schizoaffective patient, really thinking about this is a 50-year-old patient that has a diagnosis of schizoaffective disorder. So really being thoughtful about how we discuss behavioral health conditions within our system. So those are the areas of work that they have decided on, and they will be working in the coming months on really honing in on more project details, and outlining timelines for each of these projects. And that's the update from Equity of Care.
Thank you. Jose, any questions, comments?
No questions. Thank you. By the way, Fenioski, we have Kim Mendes on the line if you want an answer to a question about my chart. So,
Oh, that would be great.
But no questions on the
Okay.
presentation. Thanks.
Oh, thank you, Jose, for letting me know. I didn't notice it. Thank you, Kim, for joining us. We had a question by Dr. Shamani, who is the representative from our Department of Health and Mental Hygiene, in terms of the MyChart activations and numbers. And Dr. Shamani, do you want to ask the question directly, or do you want me to phrase it?
Let me give it a shot. It was
Okay.
it was a question of when we're reporting out, when we hear the you know, the percent of people on my chart. Is it the registration? Is it the initial activation? Is it active use? Like, what exactly does that number mean?
Oh, it's oh Lord, I have a terrible echo here. Oh, Benny, can you hear me?
I think, Kim, you are logging through two systems. That's what I see here in the participant list. Now you drop one, so maybe now the echo will go. Can you try to talk now, Kim?
All right, let's try this.
Yeah, now it sounds is much better. Yes.
All right, so the percentage of activation is, it's a rolling 12 months, and it's the number of patients that we have that have come for a visit in the last 12 months who have activated their chart, my chart.
So in that case, only captures the initial activation. It doesn't capture if they have used it for any follow-up.
So we do have data on that as well, Penny, on the utilization. I have Sean with me now. I want to say we've actually improved our utilization on this from, like, I don't want to speak out of turn because I know we're at a board meeting, but it's like 5 to 7%, or I'll be happy to bring that back. Do you know it off the top of your head, Sean?
I don't have the statistics off the top of my head, but we certainly can get statistics. And I know Vinny and Jose and other folks asked in the IT meeting on what features people are using, how often people are logging in, et cetera. So the number is correct, as Kim mentioned. The numerator is the number of people who are active. The denominator is the number of people who have a visit of any kind, whether that be an ambulatory visit, a inpatient visit, ED visit, et cetera, over the last 12 months. But we can certainly get you a lot more statistics on anything drilling down to which features people are using, which I know was something of interest in the previous meeting, or as well as, you know, how often people are logging in.
And I think the other, go ahead. Yes, I'm sorry.
Does the denominator exclude people who've already activated?
No. So the whole denominator is anyone that we have seen at a health and hospitals facility in the last 12 months.
So it's a cumulative. It's a cumulative activation then? Is that what it is? I'm trying to think, right? Because it's including, the activation could have happened 2 years ago if they were seen a month ago, correct? They could be having used my chart for some time.
Correct.
It's
Correct.
the unique patient, though.
Correct. It's so right. So if I was seen, what month are we in? We're September. So if I was seen in August of 2020, I would not be in the denominator, even though, but I wouldn't be in the numerator either.
Got it.
But then if I was seen tomorrow, and I'm active, then I would become in the numerator and the denominator for next month's statistic. Did that answer your question?
I think so, yeah.
Because it's a rolling 12, it's a rolling 12
Right.
months.
Right. So if you know, right. So if I was seen last September, right now I would be in the denominator, and if I'm active in the numerator, if I don't get seen again, when we get to October, I will be out of the denominator and the numerator, potentially.
Shamani, does that help, or do you think that we should have a more detailed follow-up?
Well, I think that it tells you, I just want to make sure I'm correct. It tells you the cumulative number of people who've been seen recently who have had at least some type of activation. It doesn't necessarily mean that they are interactive on my chart. And I think that might have been the question that both Jose and I had, and maybe some others of, you know, and the question really, you know, I mean, it's pretty incredible that the numbers are going up. It's great. I think the question is, how easy is it for people? And it could be, if the language isn't right for that person, but they have someone in their household to help them, that's okay too. You know, I mean, I think that's the other thing, is we'll never really know if it's the person themselves or somebody helping them, but having a sense of how much people are using it. And I just don't know what that number should be, because some people are not going to need a visit all the time, or aren't going to need to chat all the time. So I don't know what the metric, you know, what that bench post should be, but it's probably worth looking at.
So we do have that, Cindy, and Jose, we can provide that follow-up to this committee about the utilization component of that. And it also, I think it's interesting to look at those patients who are you know, who are part of our primary care panels, so we can see the utilization of those individuals. And I say that because we may have an individual who will come in and have, and we saw this at the beginning, a COVID test. And then they would activate, you know, their My Chart to see the test. And that was one of the questions when we first started, and we were able to pull away that, you know, that number of individuals from the denominator, so we could see, really, you know, truly see our primary care patients who are on our panels, you know, what was their activation in. And in fact, the percentage of activation went up, not down.
Okay, great.
Yeah.
Thank you, Dr. Shamani. Is that okay, or like any other questions?
Nope, not for today. That's good.
Thank you.
Probably just follow up later on other types of activation, like interaction, not the activation. But it sounds like you have it, and you'll present it another time, which is great.
And Benny, we can I'll have that on our agenda. We'll put that in our next EITS meeting as well. I know we spoke about that from a My Chart perspective, so we'll ensure that we add that.
Thank you, and we can maybe, Yanni, maybe we can invite Dr. Chamani, and of course Jose usually is there to hear those details. Another thing, Kim, as you're looking at that we asked Mathilde, was the number of languages. You know, we have 13 top languages, but my chart only currently may have only 3 of those languages. And maybe at that point, if you can also give us an update on how we are working with my chart to ensure that we also have the languages in the system.
Absolutely, we'll follow up on the language as well.
Thank you, Kim. Thank you, Sean. Again, I appreciate it that you jump in and were able to answer some of the questions. So I really appreciate it.
Our pleasure. All right, bye-bye.
Right. So we are going back to Dr. Davis' presentation. I know that I asked Jose if he has any questions. Dr. Allen, any questions for Dr. Davis? You remember we were talking about equity of care.
No questions from me.
Thank you. Sally?
No, I think it's important to look at the usage in as many ways of Epic, many ways as My Chart, in as many ways as possible. So it's great that they're doing.
Thank you, Sally. Dr. Shamani, any question about equity of care for Dr. Davis?
I'm good, thank you.
Thank you. Thank you, Dr. Davis. I know that we are running a little bit tight and we have several other things, but I think we have monitoring and evaluation. I don't know who's doing
Sure.
that report.
I am, Natalia.
Okay.
Okay,
Natalia,
so-
Chris.
Hello. So for monitoring and evaluation, we have two co-chairs, Dr. Kamal Bajaj, the Chief Quality Officer at Jacobi, and Stephanie Majak, the Director of Tech Education Programs. Currently, this work group has 8 members with 6 facilities represented. The status of work is building a collection of training and key demographics. Fields are now more accessible for use within MyChart, in particular, allowing race, ethnicity, and language fields to be entered by patients, and work group meetings have commenced and ongoing. Any questions? I know we've spoken a lot about IT, and Matilda can speak to the work that they've done within MyChart as well, within monitoring and evaluation.
Thank you. Jose, any questions?
No questions, thank you.
Dr. Allen?
Questions?
Sally?
No, thank you.
Dr. Shamani?
Nope, good, thank you.
Thank you. I just have one comment, and I don't want to elaborate here because I know that we are a little bit, but in a previous meeting, we discussed the idea of establishing goals for the different subgroups and kind of try to monitor how we are accomplishing those goals. That's not the job of the monitoring and evaluation subgroup. That's a different area. Is that correct?
Correct. So monitoring and evaluation is charged with helping the other 3 work groups monitor and evaluate the work that they are doing, and also high-level demographics that we need as a work group. So they are not sort of the dashboard of the 4 work groups to look at the data that we are working on. So each work group is responsible for their own outcome measures. And we will begin presenting that. But the goal was to really get the 4 work groups established, get members, and then we will get to that point. But we were not there yet.
Okay, thank you. That was
You're welcome.
my question. And then we have another presentation, and this is by Hilary Jallon for quality and safety.
Thank you. You all hear me?
Yes, we can hear you.
Great. So if you could go to the next slide. I know we're running really short on time. The next one. Next slide. There we go. So just to set the stage, this was a follow-up from the last meeting of this group. It was my understanding after the EEO data presentation, there was some question about patient and family complaints and grievances processes across our facilities and New York City Health and Hospitals, really specific to capturing racial inequity and gender-related harassment complaints. And what the current state is that the complaints and grievances data is not through one centralized database. It's decentralized facility-based processes. Dr. Katz got in touch with us and he asked if we could really do an assessment over the summer. So that's what we're here to present, is the results of that assessment. So this is going to be Jeremy Siegel and me together presenting this. I won't go into too much detail so that you can ask some questions along the way. But the purpose of what we're sharing with this committee today is a system-wide assessment and review of the current practices across our facilities for capturing complaints and grievances, and really specifically related to inequities. The assessment, you'll see in the next couple of slides, supports that our current processes are decentralized by facility. And what we want to really try to do, if there's time, is talk through with you ways to modify that capture so that it is a little bit more standardized. So if you go to the next slide.
Hilary, I just have a question, and I would like to ask Jose and of course all the members for input. You know, your presentation is very important one, and we did ask for this, and I know you have the detail. I'm just concerned with the time and rushing you, and don't give you the amount of attention that I think this is very important topic. And I was wondering if it will be okay to maybe have you present schedule another meeting to present this, or we can go through this. I just want to get a sense from the members. Is that okay, Hillary? I just want to
Yes,
give you the time that
whatever,
you need.
whatever all of you prefer, really, it would probably be about 10 to 15 minutes. So we could reschedule if you'd like.
Jose, what your thoughts?
I mean, we can. Yeah, let's move it to the next meeting then, or we'll schedule it again. Is that okay, Hillary?
That's perfectly fine.
We have back-to-back meetings, a couple more meetings going on. So, okay, perfect.
That okay? Yeah, I just want to ask Dr. Allen, are you okay with this option? Yes. Sally, are you okay? Dr. Shamani, are you okay?
Yeah, I think that's fine. Will it go another 3 months? We can't do an interim presentation, right? Just from like bylaws?
No, we can schedule. Well, I'm speaking
Okay.
maybe, I think Alicia is not here, but Janet can correct us, but I think we can schedule a meeting and present this.
Yeah,
We don't have to
we'll
wait
work
3
it out.
months. Yeah, we will work. I just feel that you are going to be rushed, and this is so important topic. If it is okay, Hilary and Jeremy, are you both okay?
Perfectly fine. Chair.
Yep.
Okay, so we will put it in the top of the list for the next meeting and schedule it. Yanni, can you help us with that?
Yes.
Okay, thank you so much. And again, Hilary, I apologize for this, but I feel that it's important for us to devote the necessary time for this important topic. So any old business, any new business? So if there is no further discussion, I would like to adjourn this meeting. Thank you so much. I really appreciate everybody. Thank you.
Minute.
Dr. Zamora, if I can remind you
second.
to,
Yeah.
yes, please, the minutes.
Oh, the agendas, the minutes, yes. We need a vote, sorry, Jose, we're waiting for you. I would like to propose a motion to adopt the minutes of the Equal Employment Opportunity Committee or the Equity, Diversity, and Inclusion Committee that was held in June 7, 2021. I will ask, anybody second?
Second.
Second?
Okay, Jose, your vote?
Yes.
Dr. Allen, on behalf of Dr. Katz, your vote?
Yes.
Sally?
Yes.
Dr. Shamani, okay, on behalf of Dr. Morse. Okay, thank you. I appreciate it. So with this, we will adjourn the meeting. Thank you so much. And Hilary, I'm looking forward to your presentation.
Me too.
Thank you.
Thank you. Bye-bye.
You well, everyone.
Yes.
Bye-bye.
Dr. Peña-Mora, you have a question here?
For me?
Yes, if we can correct the record to reflect that Shade Changmi is voting on behalf of Dave Shastri.
Oh, Dave Shastri, sorry, I apologize. It's not Dr. Morse, yes. Is that okay?
Yes.
She was voting on behalf of Dr. Shastri. Okay. Is that good?
Yes, thank you.
Okay, thank you.
Thank you.
Thank you, everyone.
Bye-bye.